Everything rises and falls on leadership. The ability to lead well is fueled by living your cause and purpose. This podcast will equip you with the tools to do just that. Live and lead with cause and purpose. And now, author of the book, The Anatomy of Leadership, and our host, Chris Comeaux.
Hello and welcome. I'm so excited today. I have two special guests with me. I've got Annette Kiser, the Chief Compliance Officer with Telehealth Collaborative Network. Welcome, Annette.
Hi, Chris. Good morning. It's great to be here.
And then we got Judi Lund Person, who's a principal with Lund Person and Associates. Welcome back, Judi.
Oh, thanks. It's good to be here.
Anytime I get to hang out with both of you ladies is a wonderful thing. Now, I can't imagine we have a listener who doesn't know who you are, but just in case, let me introduce you both. So first, Annette, she's the Chief Compliance Officer at TCN. She has more than 40 years of healthcare experience. She's recognized for her regulatory compliance expertise in the hospice community. She holds a master's degree in nursing administration, nationally certified as a nurse executive in healthcare compliance. Annette began her career as a nurse volunteer in 1986. She was 12 years old then. Before moving into full-time hospice nursing leadership roles, her experience includes more than 2 decades with community-based nonprofit hospices and more than 6 years supporting hospice and palliative care providers through 2 state associations with a focus on quality, compliance, clinical care, and public policy. And then Annette joined TCN in 2017, where she's partnered with hospice and palliative care leaders nationwide to strengthen their compliance practices, help them respond to surveys, audits, and navigate the wonderful complexity that is our regulatory challenges. Away from work, Annette enjoys spending time with her husband, Ron, their daughter, Taylor, and her new son-in-law, Anthony, and their 2 grandkitties, Jasper and Onyx. Annette, anything I leave out you want to add?
No, that was more than enough, Chris. Thank you.
Awesome. And congratulations on the new son-in-law. That's
Thank
actually
you.
a really cool addition. So Judi, she's the principal of the newly established Lund Person Associates. It's not new now, but it's been new for a little while.
Right.
That does hospice consulting. Judi has, for 21 years, she served as the Vice President of Regulatory Compliance of the National Hospice and Palliative Care Organization, where she served as the key contact with CMS and also other federal agencies, helping to ensure that NHPCO's voice was heard with policymakers. She is known for translating complex regulations into plain English. She has a lot of superpowers. I definitely think that's a superpower for hospice providers and providing resources for regulatory compliance. Prior to joining NHPCO, Judi served for 22 years as the president and CEO of the Carolina Center for Hospice and End-of-Life Care, where she provided support and resources for hospice providers and the end-of-life care coalitions in the Carolinas. Early in her career, Judi was part of a small group of advocates that worked for the passage of the Medicare hospice benefit in Congress, which we're all blessed by. Think about, if it wasn't for Judi, I'm not sure we'd even be here having this podcast today. That advocacy work resulted in the addition of hospice to Medicare in 1982, with the original hospice conditions of participation published in 1983. So Judi, always like to tell you thank you, because in many respects, you're one of our matriarchs.
Yeah.
And yeah, I thought about saying, like, most people like the most wonderful time of the year is like Christmas. But for you two, it's like when the wage index comes out.
You're right. You're right. It's a big deal, of course.
I don't know if anyone else is like, oh my God, it just came out and I'm going to spend all weekend reading it. I'm like, who are you? But you're 2 amazing, talented ladies. And I'm so glad I get to have a conversation with you about this. So you guys ready to jump in?
Let's
Ready?
go.
We're ready.
All right. So I just did a wonderful tale there of what we're going to be talking about, the wage index. So the final 2027 hospice wage index and final rule is now out. As I've maybe matured in my career, I always believe that the wage index is more than a payment rule. It really gives us some interesting insight to how CMS is thinking about things, their strategic thinking. So beyond the reimbursement updates, what signal is CMS sending about where they want hospice care to evolve over the next several years?
So, I always look at the final rule, even the proposed rule, but the final rule in particular, as a way to read the tea leaves. And I know I am like nerdy in that way, if you will. But so this year is no different. So I pulled out a few things that I thought would be really interesting examples. But I think for anybody who wants to know what CMS is doing, a close read, even if you spend 2 or 3 different sessions reading parts of it, of the CMS commentary and the CMS responses to comments from comment letters is very, very helpful. So here are a couple. So as we know, and we'll talk about a lot more, the Hospice Election Statement Addendum is mandatory effective October 1, 2026. And so one of the things CMS was responding to is comments about the addendum, and obviously their comment, which you'll hear in just a second, is because a lot of commenters said the form was confusing and burdensome and so on and so forth. So here is what CMS said. CMS said the addendum must include a clinical explanation in language that the patient or representative can understand of why the drug, item, or service is unrelated. And then the translation to that, this is one of those tea leaf things. The translation to that is stop whining and get this implemented. And I also thought about experiences in my career, especially at NHPCO, where we would talk to CMS, or we would go to CMS. And I remember one time we were in Baltimore, and somebody was walking me out the door, and I said, thank you so much for, including blah, 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 whatever it was. And she looked at me and she said, well, Judi, we've been telling you this for 5 years. So it's about time you got it together. That's the same kind of category of this. So stop whining, get this accomplished. Another example, and this is like seriously nerdy. So we'll go there for just a second, but we've had a lot of commentary about what to do about unrelated drug services and treatments. And CMS over the years has said, the words you should be using in your election statement are unusual and exceptional. So we've argued with CMS and with the MACs about this issue over some time and said, sometimes people use the word rare because it's more understandable to the patient and their family. So this year, what do we have? Here's the CMS sentence. Unrelated items, services, and drugs should be exceptional, rare, and unusual. And all of a sudden, now we have it in CMS language. And so we can now use this. And a hospice can use this language and say, you can no longer deny my election statement form as being invalid because I used the word rare. It may seem like a really small thing, but it is not. And so another kind of read the tea leaves, CMS is starting to get what's going on here. And then I just add a third thing, and I think for all of us who really believe in high quality hospice care, this is when it's hard, I think. So we know that there's a lot of focus on hospice fraud, waste, and abuse. And so one of the things that CMS puts in the report about why we are focused on this is the things that hospices, they have reports from advocates, they have reports from families that hospices did not provide. Look at this list or listen to this list. Wheelchairs, hospital beds, oxygen supplies, wound care supplies, incontinence supplies, catheters, needles, and common palliative drugs. And so this is another one where reading the tea leaves is because CMS is seeing this, we have a responsibility to really dig in and make sure that this gets corrected. So just a couple of examples I think that are interesting and certainly give us some roadmaps for the future.
Wow. Annette, any tea leaves you want to read?
Well, I'll just tag on to what Judi was saying about, what it's hospices not paying for things they should be. CMS pointed out in the commentary that Medicare payments just for non-hospice Part A and B, that doesn't include Part D medications, but just for Part A and B, that increased 160% from 2020 to 2024. And in 2024, the non-hospice spending for Parts A and B was over $2 billion.
Billion with
so
a B.
$2 billion.
Right.
Billion with the B. And important piece that hospices don't often think about is patients have cost sharing for Parts A and B. Anybody with Medicare and goes to the doctor or the hospital, they got to pay their part. Hospice patients had $510 million in cost sharing for Parts A and B services billed to Medicare just in 2024, $510 million in cost sharing. And so that's really where it gets important. And Judi mentioned the addendum, and that's about transparency for patients as to what they are going to be expected to cover that's unrelated to that terminal illness and related conditions. But it's a lot of money, and when you stop and think about that, that's a big reason why it's getting CMS attention.
Wow. Well, love how you guys just jumped in. Let me ask it this way. If a hospice CEO only had 5 minutes to understand this rule, what are the 3 most important takeaways?
Well, I would say the addendum. Judi said it, October 1, and today is August 14th. We have 6 weeks to be ready for this. And I talked to a hospice just yesterday, and they haven't even had a meeting yet to think about how they're going to implement it. Others started back in April when the proposed rule came out. So they need to understand the addendum and make sure someone is assigned to be the project leader in their organization to get that going, because it's significant. Every Medicare patient has to get the addendum within the first 5 days of election of the benefit. And I'll have a little caveat because of a conversation I had earlier today with the hospice. It's at election of the benefit. If a patient turns 65 later, if you have to discharge them and readmit because you missed the face-to-face, you get to do a new addendum because it's based on the election of the Medicare benefit. So CEOs need to make sure someone is has been tasked with being responsible for getting everyone together to make that process happen. And then Judi's going to talk more about this in a few minutes, but the SSVI, the Service and Spending Variation Index, is huge. CMS did not make changes to that. They updated the data a little bit, but basically it's there. Hospices get those scores based on their utilization statistics and based on their non-hospice spending. And so CEOs need to make sure there are multiple people looking at those metrics through a quality improvement lens, not just this data. CMS focused on those hospices, and there are only 69 of them that had a score of 13 or greater as being above the 99th percentile. But what Judi and I talked about is over time, less hospices are going to have a score of 13, so the threshold's going to lower. And so any hospice that has any points in that score really needs to pay attention. So CEOs need to make sure multiple people are tracking and they know how to track. And Judi's going to talk a little bit more about that. And then just a couple little things unrelated to the addendum, the SSVI and the wage index, is all hospice physicians can now write discharge orders. It used to be just the medical director. I have a feeling that hospices have been using others, but now it's official that any hospice physician can write that discharge order. We are going to have the G code that should be coming out soon, that beginning January 1, 2027, hospices have to put that code on their claims if they do a face-to-face visit by telehealth. CMS wants to know how much telehealth is being used. And then I would just encourage at some point, make time, as Judi said, it'll take a couple sessions, but sit down and read what CMS had to say about the request for information comments they got back regarding medical aid in dying, regarding palliative care, and hospice payment reform. It gives some good insight into what CMS is thinking.
Yeah, I just want to put an exclamation point on that. Annette, you're the one who taught me that those RFIs are their tells as well, tea leaves as well, like what they're thinking about going forward. So that's fascinating, that MAID, palliative care, and then other payment reform. And then I want to ask you, Annette, but Judi, you could comment as well. Is the G code and telehealth a bit of a tell also, or don't read anything into it? I mean, I could understand why they'd want at least had a way to segment that data, but do you think it's a tell in any way, shape, or form?
Well, I think it might be just a little bit, because there is some concern that telehealth is being used, and there are so many concerns about eligibility determinations. And if it's telehealth, it is harder, depending on the patient, to make some of those assessments. What my word of encouragement is, if you are feeling pretty confident that patient's eligible, telehealth is okay. I would encourage to have a nurse in the home to help ask questions, turn the patient, answer some of those questions for the provider. But if that patient is a little less clear, some of those patients that decline more slowly, an in-person visit may be good. And I think if we want to be able to help CMS understand there's a role for it, having that code lets them know we are needing to use it. But as we all know with anything, it could come a time when they look and see, oh, this hospice does 100% of their visits by telehealth, and that could be some concern.
Well, let's talk more about the SSVI. Like, we need one more acronym, right? Well,
exactly.
My wife is listening to me in a Zoom call, and she's like, "Do you guys have like your own language?" I'm like, "Yeah, we do. It's a bunch of acronyms."
And just when you think you understand it, they're going to add a new one.
Right.
Absolutely. So, what first step should a hospice take now that they can actually see their own SSVI data?
Well, let's kind of pull it apart just a little bit as we start, and also kind of think about what's in that SSVI report. And if you downloaded it from the CMS website, it is 6,200 rows of data, but it includes every single hospice in the country. So it's all public data. It all comes on the utilization side. It all comes from claims data. On the non-hospice spending side, it comes from non-hospice providers and links it to the enrolled hospice beneficiary. So I think that in itself is daunting. All of a sudden, you can see all this information about yourself, your own agency, but you can also look at others in your state, your competitors, any of that kind of thing. So the whole issue with SSVI is, let's start with utilization metrics. The utilization metrics are things that are pretty commonly already known. So things like, did you provide any GIP or continuous home care? If no, you get a point of 1. Maybe we should stop there and talk about the point system. So on the utilization metrics, there are 8 points. And you get a point if you hit a threshold that's specified for this year, but for this year only. Kind of to Annette's point, this will change over time. But when we are looking at a utilization metric, so that's 1 point. But there are 8 of them. And things like what percentage of your census was in a nursing home or skilled nursing facility? If your percentage of nursing home residents who have hospice is greater than 40%, you get a point. They're looking at nursing minutes. They're looking at visits done on the weekends. They're looking at that score for HVLDL. And if you are at a certain threshold, and the threshold is specified in the final rule, but also many of us who've been talking about this are trying as hard as we can to turn it into plain English a little bit more. But I think these are not big surprise metrics. Percentage of hospices percentage of patients who have a live discharge, percentage of patients who have a length of stay greater than 180 days, that sort of thing. What we're seeing in the data, as Annette said, this utilization metrics, 8 points, and then non-hospice spending, 8 points, is, I think, not so concerning on the utilization side. But certainly, as we move to the non-hospice spending side, when the proposed rule came out, we said, we looked at the non-hospice spending, and it is 8 categories by the amount of the spend. So you get 1 point if your non-hospice spending in FY25, the year we are looking at data-wise, is $6,500 or more. 1 point. Now, it doesn't matter at all if you had 20 patients that year or if you had 6,000 patients that year. If you had non-hospice spending of $6,500, rounded number, then you get a point. And so I bet you all of us who wrote comments on the proposed rule said, this is not right. This is unfair. This does not take into account the size of the hospice. But the non-hospice spending metrics were finalized as proposed.
If I could jump in, Judy, the bigger concern for me is those who get a score of 8. If you have more than $515,000 rounded, you get a score of 8. So a hospice that has an average daily census of 500 and has more than $500,000 is going to get the same score as a hospice that has an average daily census of 50. Well, you would expect that a larger hospice has more non-hospice spending.
Right.
CMS did not change that metric. And so there are hospices that all of us work with that may have a score of 8 or 7 or 6 because of the size. And some of that non-hospice spending is legitimate, such as Part B, attending physician visits. But CMS didn't extract those things. And so it's important to understand how that scoring comes.
So I think then there's a second issue with the non-hospice spending part of this, and that is, do we even know when non-hospice spending is occurring? And that I think is, the bigger issue, and this is what a hospice should be looking at, is where can I find, especially Part B, because that's going to be a lot of it. Part D, I think, is maybe more of a black hole, but on the Part B side, where can I find data that is patient specific, beneficiary specific, and you begin to put together what spending what occurred. I will use an example of a provider I talked to recently who said, my non-hospice spending was $1.6 million. I serve 2,000 patients a year. And I have no idea where that spending came from because we have never had information that gives us insight into who billed for what patient. And the only way we're going to really correct this is to have that information. So, I think now we're beginning to look at what vendors have Part B claims data that is patient specific. And that's, if I on my list of things a hospice should do immediately is figure out where you can get that information, because this is the only way you're going to be able to correct the non-hospice spend. Now, I will do maybe an editorial comment as well, which is, as we talk to CMS about the SSVI, about the non-hospice spending, I remember one conversation I had with somebody at CMS, and I said, well, you're aware, of course, that most hospices have no idea where this spending came from. And her response was, oh, no, that's not true. We know that hospices are pushing claims or pushing services over to the Part B side so that Part B will pay and the hospice doesn't have to pay. And after steam came out of my ears, after I was like, okay, take a breath, Judi, don't damage this relationship. I said, no, I don't believe that's completely true. You may be seeing that from some providers, but the vast majority of providers have no idea where this non-hospice spending is occurring. So, but on the short list of things to do is pull this non-hospice spending data apart. See what you can get in terms of patient level, beneficiary level, matched with your hospice enrollment data, so that you can reach out to whoever it is that's billing. Now, the other comment I would make, also editorial comment, is Annette and I both worked on this, that for years we worked on trying to convince CMS to put some flags in the claims processing system that if you were a hospital, an outpatient clinic, a doctor's office, a whatever, there would be a block on filing the claim until the hospice was contacted, until you figured out whether the claim should be filed or whether the hospice should pay. That part of claims processing has never been fully implemented. And so that's the other piece we have, is we have to do the digging. And I guess my own passion about this is that is the only way we're going to solve this non-hospice spending. And And that is right. I mean, we are looking at huge, huge, huge volume here. So there you have it.
Would that be hard for them to do, Judi? It seems like it'd be fairly simple for them to just put like a flag. If that Part A has been elected, that it would just flag the system and they couldn't put that bill through.
It should be easy. Now, when you look at the data, the percentage of the total that was Part A has gone down significantly over the 5-year period, while Part B has just expanded. So it should be easy, and maybe once they have the moving the claims processing system to the cloud and some of those things are accomplished, maybe that'll be an easier lift.
Do you think that'll be in our lifetime, Judi?
I don't know.
When Annette had originally shared the first round of reports, wasn't wound care like the tops on that list?
No.
Did I misremember that? No,
Yes, it was actually skin substitutes were a huge part of the reason that the non-hospice spending has grown so much. Skin substitutes for Medicare in general is a huge issue, never mind the hospice part of it, which was also huge. But one of the things, again, that reading the tea leaves, the CMS commentary on it was to say, yes, we have addressed wound care specialists. We have addressed skin substitutes, but that does not negate the responsibility of the hospice to pay for wound care when it's related to the terminal illness. So, I mean, yes, we've got all of these things, and certainly a lot more conversation needs to be had with CMS.
And I was thinking about interjecting this when we were talking. So obviously more points is not good. This is like dominoes in golf. You want a lower score as possible.
Yeah. Absolutely. If you can have a zero, it's great. I don't expect zero because, again, some of that spending, non-hospice spending, is legitimate.
Right.
So a hospice may have a score of 1, 2, 3. It's the 6, 7s, and 8s that we need to be more concerned about, as long as CMS continues to use the spending categories that they are.
And Judi, so it's weighted about 50% utilization and then 50% non-hospice spending. So it's kind of like a weighted average based on those two categories.
Right. It's weighted on the number of points. But because the non-hospice spending has no connection to census, it's weirdly weighted on the non-hospice spending side, unfortunately.
Yeah. Okay. Wow. And SSVI stands for, because once we get the acronym, we totally forget what it stood for originally.
Service and Spending Variation Index.
Okay. Perfect. So what first steps would you guys recommend a hospice should take now that they can see their SSVI data?
For me, it is you can see both FY24 SSVI data and 2025. Now you also have the PEPR, and so you are looking at 2 years of SSVI, soon to be, but we won't have 26 data until next year, and then 3 years of PEPR. And for me, I think you are, a hospice is going to be looking at all the trends. You were saying, okay, how did I do in 24, even on the utilization metrics? Did I improve in FY25? Did my number of metrics, did that lower score happen in 25 compared to 24? That would be one thing. Then I think some of these are overlapped with PEPR. And so I have been begging the PEPR contractor to release information on percentage of hospices who have downloaded their PEPR or percentage of hospices by state. And neither one has happened so far, but it's early yet. But I think that's the other thing, is take a look at your PEPR and say which one, and maybe Annette and I between us will figure out some alignment to say this metric in the PEPR matches this metric in SSVI. Start to really look at that, peel it apart, look at every single metric. And I guess my only other comment would be review early and often. We've got a lot of really, really great metrics. You will learn, I think all of us will learn something about the hospice that we work for, the hospice that we love working for. So, and opportunities, definitely opportunities for quality improvement.
Wow. Well, I think you two have done a good job us kind of laying okay, so this is what's in the wage index. So as we go to this next segment, every final rule creates opportunities for some organizations and challenges. Which type of hospices do you think are positioned to succeed under this year's rule? And which organization should be paying maybe really particular close attention to it?
Don't miss part 2 of this episode coming this Friday.